Hey guys, my name is Amira Saeed and I'm Assistant Lecturer of Medical Microbiology and Immunology. First of all, I hope you are all safe and follow the precautions we have taught you before, most importantly, hand hygiene techniques, of course. So keep calm and keep studying. Today, we're gonna talk about lower respiratory tract infections. So we should first know what is the difference between the upper respiratory tract and the lower respiratory tract. Of course, you have learned about it in your lectures, so you know the upper respiratory tract including nose, sinuses, pharynx, oro and nasopharynx, and larynx above the vocal cords, and the lower respiratory tract including larynx below the vocal cords, bronchi and bronchioles. So the lower respiratory tract infections including laryngitis, tracheitis, bronchitis, bronchiolitis, and pneumonia. Today we're gonna talk about the pneumonia. Okay, pneumonia is classified according to the clinical presentation into typical and atypical. Typical pneumonia have rapid onset, more severe symptoms, productive cough, and dense consolidation on the chest X-ray. But the atypical pneumonia have lower onset, less severe symptoms, non-productive cough, patchy interstitial opacities on the chest X-ray. The most common causative agents in the typical pneumonia, if you are a clinician receiving patients with the symptoms of typical pneumonia, you should suspect one of these organisms. As we put differential diagnosis for any infection, we should think systematically. So we think there are gram-positive organisms and there are gram-negative organisms. The most common gram-positive organisms causing typical pneumonia are Streptoneumoniae and Staph aureus. But the most common organisms causing typical pneumonia, which are gram-negatives, are Klebsiella pneumoniae, Pseudomonas aeruginosa, and Haemophilus influenza. After suspecting typical pneumonia, how can you proceed in diagnosis? If you remember the first step you do in real life, or if you are writing in your exam, in laboratory diagnosis for any infection, the first step is specimen collection. So in typical pneumonia, there are the lower respiratory tract samples and there are other samples. The lower respiratory tract samples we are collecting are sputum, bronchoalveolar lavage, and endotracheal aspirate. The other samples are blood for blood culturing, urine for pneumococcal antigen detection, as we will discuss later. As a sputum sample is the most common sample, we need to know how to ensure that the sample is up to the criteria and to give us an accurate result. First of all, the timing of taking the sample. You should advise the patient to be in early morning after deep cough to ensure that it is sputum, not saliva. And of course, before initiation of antimicrobial therapy. The container should be sterile, dry, wide-necked, and leak-proof container, as you see in this picture, which is called universal container, but it is the sterile universal container. About the transport of the sputum sample, you should avoid the delay of the specimen. You should transport it to the processing area as soon as possible because some causing organisms of the typical pneumonia are fastidious and can die easily without appropriate environment. As for patients without spontaneous sputum production, this is done by inhalation of nebulized sterile saline solution followed by coughing and expectoration of airway secretions. And as so the sputum is usually contaminated with small numbers of commensals in the upper respiratory tract like Streptococcus viridans and diphtheroids, every microbiologist should know that sputum contains commensals which shouldn't be reported as pathogens when it appears in cultures. Other samples for typical pneumonia including endotracheal aspirate, which is in the mechanically ventilated patients intubated with endotracheal tube and on machine supporting ventilation. The other sample is bronchoalveolar lavage, known as BAL. It's a common term, you will hear it every now and then. So it's better than the sputum as reducing chance for the upper airway contamination, but it needs technical skill and equipment. Whenever possible, specimens should be processed in biological safety cabinet as to protect the lab worker from possible organisms in the sample as well as to protect environment, as we learned in the containment lesson. As we learned before, the steps in processing samples are as follows. First, the direct gram stain, which we are calling direct as it comes directly from the specimen. Then we culture the specimen on suitable culture medium. Then the colony is identified by its colonial morphology, another gram-stained film which we are calling indirect film, then biochemical reactions and other tests, and the last step is the antibiotic susceptibility to give the clinician the full lab report. Of course, in the first step with the direct gram smear, we see bus cells, which are pink cells in both pictures with segmented nuclei. If you see in the left picture, we see diplococci, so we are suspecting strep pneumonia. On the right picture, you see pink rods, so we are suspecting gram-negative bacilli like Klebsiella pneumoniae, Pseudomonas aeruginosa, and Haemophilus influenza. Value of the direct gram smear has a great value because first of all it guides us about the quality of the specimen. To accept the specimen, it should have abundance of bus cells and few squamous epithelial cells. The second benefit from the direct gram smear that the result is usually available in the same day, so it can direct clinicians about the antibiotic therapy, the primary antibiotic therapy, till the full culture results will appear. In this part of presentation, we want to teach you about what to do if we are suspecting a case of pulmonary tuberculosis, as the processing of sample will differ in huge way. First, in specimen collection, it should be early in the morning for the sputum, and we should take the sample for 3 successive days to be reported negative. We can also take from the patient bronchial washes or pleural fluid or gastric aspirate, especially in cases of children. As you should know, Mycobacterium tuberculosis, the bacteria causing the pulmonary tuberculosis, can't be stained by gram stain, as it has thick wall with high lipid content. So there are two different methods to stain these bacteria. First is the acid-fast staining with Zell-Nelson stain or cold Kenyan stain, and the other is fluorochrome stain, which called uramine-rhodamine stain. We need to teach you about the steps of Zell-Nelson staining. First of all, you should apply your primary stain, which is a concentrated carbofuran. If you remember, it was the last step of the gram stain, but it was diluted. Then we apply the heat underneath the slide to force the stain to stain the bacteria. Then we apply the decolorizer agent, which is mostly the sulfuric acid, and the last step is the counter stain with the methylene blue. So it's called acid-fast staining because the TB bacilli resist decolorization, meaning casting from decolorization by sulfuric acid and remain pink on blue background. The left picture demonstrating the Zell-Nelson staining. As you see, the pink bacilli marked by the black arrows on the blue background, which is the methylene blue. On the right side of the picture, we saw the fluorochrome staining. The fluorochrome staining, we use fluorescent microscope, not ordinary light microscope, which use the UV light. So the bacilli fluoresce on black background. To isolate Mycobacterium tuberculosis, sputum sample first must be decontaminated to prevent bacterial overgrowth, liquefied to facilitate concentration by centrifugation, which is the last step, then isolated on suitable culture media, which may be traditional or commercial. The traditional culture media including liquid or agar-based called Middlebrook or egg-based which is called Levenstein-Jensen media appearing in the left picture as green slope. The organism take from 4 to 8 weeks to grow on these medium, and there is the commercial growth systems called Mycobacterial Growth Indicator Tube, abbreviated as MAGIT system. The organism take to grow on this media from 2 to 4 weeks. The idea of MAGIT that it's formed of liquid media as you see on the right picture with oxygen sensitive fluorescent sensor embedded in the gel in the bottom of the tube. So when the organism utilize the oxygen in the media by multiplication, the sensor in the bottom of the tube fluoresce and it appear under the ultraviolet light.